Jamil, I'm gonna break this up a little bit. So Jamil, I'm gonna come to you and, okay, here's a drug where in the 2 indications, you can find doses in the package insert for 20 BID, 15 BID, 10 BID, I know that's PV, and then 5 BID. Mm-hmm. What's a doctor supposed to do? How do you pick the starting dose?
I think it's safe to say, okay, the least effective dose is 10 milligram BID, but I think it's reasonable to also go by the platelet count, exactly as was done in the study. And I think every patient has to be evaluated individually. Like if you may have someone who may have a touch of kidney dysfunction, well, I probably won't be starting with 20 BID, even though their platelet count may be above 200. So each person has to be assessed separately.
Okay. And Mary Frances, how do you make dose adjustments? One of the current concerns I've heard, I'm going to come to you with this question, then you could talk about dose adjustments. One of the concerns I've heard about using Rux is, you know, I know the patient's symptomatic, but they're not red cell transfusion dependent. I'm afraid I'm going to make them that way. Or alternatively, oh my Lord, they have so much red cell transfusion requirement, it's only going to get worse. Seems like a catch-22 to never use the drug.
I think that's the most difficult one, particularly the sort of patient, because it certainly makes people anemic. And if you change somebody, particularly I think from not being transfusion dependent to being transfusion dependent, but it does plateau, so it may come up a bit. You can add in particularly erythropoietin stimulating agents to see if you can push their hemoglobin up. And I think drug that is so effective, how long do you hold off using it just on that? I think that's probably not an argument if they've myelofibrosis to the extent that they're anemic. So what dose do you start with? Well, I think it very much, it's the platelet count. You want to try and get as much as you can in, so you want to get to the 20 BD if possible, but the instructions are quite clear on that. If the platelets are over 200, you can do that. If it's 100 to 200, you have to start at 15 BD, and 50 to 100 lower. And of course, if the platelets are under 50, you're not supposed to give it, though I think many people will start ruxolitinib and hope that the platelet count will come up with time. With a lower platelet count. And again, once you've started, if the counts improve, you can get the dose up.
Yeah, it is interesting. In PV, in the first 2 weeks, the platelet counts did go up in the response trial, right? And I think that's more because you get rapid reductions in splenomegaly, and it's still a proliferative disease, but we don't see that.
And of course, the one thing you do see when you start people in ruxolitinib is the white cell count goes way up, and that can be quite alarming. You have to sort of hold your nerve and keep going, because they can get very high white cell counts temporarily.
So you don't adjust the doses based on whether the patient's required a red cell transfusion. It's platelets, or
the platelet.
Anything else?
Yes, the platelet count.
Anything else where you've had to adjust it?
That's the main one.
Okay.
I think the key is like really the close observation at the beginning, like the first couple of months. The nadir of the counts is typically around 8 weeks to 10. And that's where you need really to titrate the dose. If the patient is tolerating well, I think titrating the dose early on has benefits, so those patients get better. But also, you know, we don't want to render those patients to become transfusion dependent if the dose is very high. I clearly see a dose-dependent spleen response. So the higher the dose, you know, the spleen response is better. For symptom improvement, actually, patients do relatively well on a lower dose. So like they get benefit from the lower dose in terms of like symptom improvement, but definitely a dose, you know, spleen dose-dependent response that needs a probably 15 and higher to see really good spleen response. But that also brings me to a point I always think of is like, what is a meaningful spleen reduction for the patient? We've got into all those studies where our primary endpoint now is that 35% reduction by MRI for the volume of the spleen, which correlates with 50%. But in reality, with those treatments,
50%
reduction by physical exam.
exam.
But in reality, like almost more than 90% of the patients on those treatments will have some spleen reduction. And that's what is meaningful for the patient. What correlates with, you know, better outcome is not clear to me. But like in my experience, most of the patients will have some spleen reduction with those treatments.
Okay. We know there's about a 5% incidence of herpes zoster. Do you prophylax these patients? Have you seen it?
If I'm starting a new patient nowadays, now that we have the non-live vaccine, I'm advising all my patients to receive that prior to therapy.
Do you give it a little bit of time to work before you give an immunosuppressant? What do you actually do? You just
Maybe.
give it and start the next
Well,
day?
it's 2 doses basically that they have to take, and then you could start perhaps a month later.
Okay, so you do give
Yeah,
some delay.
I wait a
Okay.
little bit, but I'm advising everybody to receive that.
Okay, I think that's helpful, because that's a change from what we've been doing. It sounds like, are you
We
doing
haven't
that?
got that vaccine yet.
Okay. Oh, you
to
don't have
tell-
the vaccine. Okay. Okay. So let's pull this together, and any closing thoughts on, what your experience has been with Ruxolitinib? It sounds like it's been generally positive, but anything that the viewer should be particularly, on the watch for?
I would say that in myelofibrosis, I think folks have learned how to use it overall. I think there are sometimes underdosing that occurs, but I think the prevalence of use is good. I would say in vera, it is underutilized. Like there are a lot of patients that are having an inadequate response to frontline cytoreductive therapy who would benefit from Ruxolitinib and are delayed in receiving it. So I'd say that's probably the biggest gap in that spectrum in my eyes.
One of the things I often say about the incorporation of Ruxolitinib into our armamentarium for PV is that it really is focused attention on the optimal management of the PV patient before we decide that they actually need Rux. Sure. Titrating the dose hydroxyurea and aspirin and phlebotomy. Any other comments?
I think the challenge now is becoming in the era of like Ruxolitinib failure. Like what would you do after the treatment stops working? We do have patients that have like durable responses, but eventually treatment stops in most of those patients. The outcome for those patients, is not the best, and the options are limited. So that's an area of unmet need for like second generation, JAK2 inhibitors, new treatments. That's what we are starting to face. Some of those referrals to us used to be upfront, decide on Ruxolitinib or not. As Ruben mentioned, now people are comfortable using those medications upfront. We are starting to see those patients when those treatments stop to work.
I think that's very true. That's a huge change. We've gone from patients that we had nothing you could do for. Now they all come, get their Ruxolitinib. That's great, and we're now getting them sent back. What are you going to do now? Because they're not responding to it anymore.